Good.
So here we go. Good evening and welcome to one and all. I'm Ankita from Planet, the designated session assistant for a seamless experience. And Planet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Planet is very proud to be a digital partner for this event organized by Society of Onco Anesthesia and Perioperative Care. And topic of today's session is SOAPC Lecture Series 19. So let's begin today's session, for which I would like to hand over the session to Dr. Anjali ma'am. So over to you, ma'am. Please proceed.
Good evening, everyone. Welcome to this session. Today we have an illustrious speaker with us, Dr. Lakshmi Kumar. She actually needs no introduction, and it is Dr. Rakesh Garg who's chairing this session, but he's inevitably delayed in a case. So I shall start off. Dr. Lakshmi Kumar is Professor Head of Department of Anesthesia and Critical Care, Amrita Institute, Kochi, as you all know. She's MD from AIMS, New Delhi, and she's interested in hepatobiliary, liver transplant, pediatrics, and critical care, in which she has published several articles in both international and national journals, and has contributed to several chapters in her area of interest. I think most of us have heard her in several fora already, so I shall not take up any more time. Over to you, madam.
Thank you, Dr. Anjali. So do I move on to share screen? Am I empowered to do that?
Yes, ma'am.
Yes, ma'am. Kindly proceed.
So right. So my topic for today is intravenous fluids in oncological surgery. Which fluid should we use? And I will go about this topic in the following headings. Which fluid is most optimal for use in abdominal surgery? Among the fluids, are the acetate containing actually better than those that contain lactate, and does it really make a difference? Do we have a role for colloids in abdominal surgery? The next question is, how do we know how much fluid to give? So does assessing fluid responsiveness help? What monitors are available? And then, of course, to liberal versus restrictive fluid strategies and fluids versus vasopressor, right? So all this is largely in the context of abdominal surgeries. And of course, the premise is most of abdominal major surgeries are malignancies. So I will try and keep my discussions confined to oncological surgery. Now, coming to the type of fluid, we know there are two types of fluid. The famous normal saline, which many of us during our MD training used and then slightly learned to move away from, versus the balanced salt solution. Now, while I might shout myself hoarse saying you have to use balanced salt solution, what's the evidence for not using saline? So I'm going to just put it, just to start interesting this thing. We have a 58-year-old gentleman who has a hepatocellular carcinoma and scheduled for a open right lobe hepatectomy, right? You induce the anesthesia, put in your usual lines, and 2 hours after commencement of transection, the resident in the theater says, ma'am, this is his ABG. pH is 7.29, PCO to PO2, okay. Bicarb is 19 and lactates are 3.5. So her question is, madam, can I continue with ringer lactate or should I change? So this is when we start thinking how right we are as to the choice of fluids. I'm still not sure whether we make the right choices, but we have a certain thinking when we decide which fluid to use for the rest of the surgery. Now, 15, 20 years ago, when we started hepatectomy, my choice was ringer lactate. And then when the ringer lactate start to rise, I would switch over to normal saline. And expectedly, obviously, I had more metabolic acidosis and definite hyperchloremia. So today we know we have better solutions. So I'll tell you what happens. Why is it that today I can't use normal saline or even half normal saline if I thought that the sodium and chloride were high? This is because normal saline, when you instill a liter into the body, causes metabolic acidosis because it contains 1 liter of fluid that does not have a base and therefore dilutes the plasma volume by that proportion of fluid that does not have a base of bicarbonate. Now, I will show in the subsequent study that when you give up to 2 liters of normal saline, even to healthy young individuals, it was shown to increase the renal arteriolar vasoconstriction and cause a reduction in glomerular filtration rate. The hyperchloremia is partly because of the content of chloride and also because of the action of normal saline on the tubular channels. So this study was conducted, I think it was sometime in 2016. I really don't remember the year. But this was a randomized, controlled, double-blind crossover study where the effects of infusions of 2 liters of either fluid, normal saline or plasma light, was looked at in 12 healthy young men. They received 2 liters of intravenous saline over 2 hours, and 90 minutes later, they were taken for MRI scanning of the kidney, where they measured the renal blood flow velocity and the renal cortical perfusion. The same patients, 10 days later, received either plasma light, what they didn't receive in the first session. That's why it's a crossover. So these patients had both the same patient had both plasma light and normal saline at different times. And what were the results? Predictably, there was sustained hyperchloremia with saline, but not with plasma light. The fall in the strong ion difference was greater with the saline group. Blood volume changes were identical, but the extravalvular fluid expansion was more with saline. And the key finding, significant reduction in the mean renal artery blood flow velocity and the renal cortical tissue perfusion after the administration of saline, but not after plasma light. There was no difference in the concentrations of urinary neutrophil gelatinase associated lipocalin after the infusions. So sustained hyperchloremia, decrease in the blood flow to the kidney, and an increase in the extracellular volume. And this graph actually shows the increase in the renal arterial blood flow, which actually happens by the chloride activating adenosine in the cells of the macula densa. And you can find that there is a decrease in the renal perfusion in the saline group. Now, this is another randomized trial which compared normal saline versus a balanced crystalloid in major abdominal surgery as a double-blind randomized trial where they compared normal saline with an acetate containing crystalloid. They planned to conduct the study over 240 patients, but actually the study stopped at the conclusion of 60 for safety reasons. They found out that the normal saline group developed hyperchloremic metabolic acidosis. More patients needed vasopressors for circulatory support. And a Cox regression analysis revealed that the need for vasopressors was more in the saline group. Right? So the patients requiring vasopressors was higher in the group that was receiving saline. Cumulative dose of norepinephrine was higher. And of course, there was hyperchloremic acidosis and increased need for vasopressor in the saline group. Now, this Shaw's study, many of you would have read, this is an older study, I think it is 2008, where they compared an extremely large number of patients, nearly 31,000 patients who received normal saline against 900 odd patients who received plasma light as a retrospective study from a database in the US from a veterans hospital. So they found that the in-hospital mortality in the saline group was 5.6% as compared to 2.9% in the group that received balanced salt solution. Post-operative infection, renal failure requiring dialysis, the transfusions and interventions for renal failure were all higher in the group that received saline, pointing in an overwhelming fashion that normal saline was not good and you need balanced salt solution. The drawbacks, of course, it is a retrospective study. Imbalanced numbers. You had 31,000 patients who came that received normal saline versus just 926 that received plasma light. And as I said, it was in the veterans thing, which was covered under Medicare. And the saline group predominantly included patients covered by medical care and were likely to be emergency surgery, which could explain some of the renal outcomes. So these are the outcomes shown by Shaw's study, where you find that the odds ratio favoring the use of balanced salt solution and interventions being higher in groups that receive saline. The SOLAR trial is a more recent 2020 study by Dr. Kamal Maheshwari. Here, the authors actually have looked at patients undergoing both colorectal and orthopedic surgery. So I presume that they didn't involve too much of blood loss. Here they found that there was absolutely no difference in the incidence of acute kidney injury, and they concluded to say that in elective orthopedic and colorectal surgery, there was no meaningful difference in postoperative complications in using one versus the other. Right. And this is a concrete analysis of the impact of balanced salt solutions, and the evidence towards using one over the other is weak. However, I think we as clinicians will probably, so in this, there is no this thing, but we all know that I wouldn't use a normal saline excessively because I would worry about hyperchloremia and possible renal impact. I would, if I had a choice, avoid the use of lactate in any situation where I believe that the lactate level could be a marker of the outcomes of surgery. Right. And then, of course, I would not use any solution containing potassium if the patient were having associated renal failure, but would try to balance a solution of half normal saline with the addition of soda bicarb. We use a formula of 37.5 cc of soda bicarb to 500 mils of normal saline, which is what we use when the patient has hyperkalemia. Now, coming to the topic of today's, what about oncological surgery? Not much is spoken about the oncological surgery. However, in this one article, where they've looked at major postoperative complications in surgery for advanced ovarian malignancy, they found about 184 women included in the analysis. And they said 22% developed a major postoperative complication. When they looked at the odds ratio, they said that patients who had a fluid balance of more than 3 liters perioperatively were more likely to develop postoperative complications, whereas there was no association between a negative fluid balance and major postoperative complication. So whether a complicated patient by default was given fluids for the management of his complications, I'm not sure. But this is a statement that does say that if you give more fluids, you could be having more problems. Right. Now, what is the difference when we are talking about the different choices of balanced salt solution? What is the difference between the different buffers? We have lactate, we have acetate, we have gluconate, right? We don't have any that directly contains bicarbonate. These are bases which actually get converted to bicarbonate within the body. Now, which one of them is best when we have to consider abdominal oncological surgery? Do we still have a role here for normal saline? Now we'll come to the judgment of would I use acetate or lactate containing solutions, right? So this next slide, or maybe the next two slides, are borrowed from Dr. Anita Shenoy from Manipal, who had kindly loaned me her lecture PPTs for this topic. So this was a very beautiful presentation where she actually spoke about the strong ion deficit in blood. Instead of the Henderson-Hasselbalch, which we commonly use, here they talk about the SID. And the strong ions, essentially, the cation, sodium is the most important cation, and chloride is the most important anion. Bicarbonate is a weaker anion, and then you have minor levels of anions, which will not be accounted for when you look at the Henderson-Hasselbalch, albumin, and the lactates, phosphates, and ketones, etc., come in this group of anions. Right now. So when I have when the normal plasma contains a strong ion difference of 38 milliequivalents, my sodium is 140 and chloride is 102. So why am I giving ringer lactate? If I look at the strong ion difference in ringer lactate, sodium is 137, chloride, isn't it 131? Anyway, 137, chloride is 109, and lactate is 28. So if I do positive minus negative, I have a strong ion difference of 0. Which is like giving normal saline, 154 minus 154. But that is not what happens in the body, right? So when you give this lactate containing Ringer's lactate, when you actually add it to say a 1 liter of plasma and 1 liter of Ringer lactate, you will find a mean of 139 sodium, 105 chloride. And the lactate becomes 0 because the lactate there has got converted to bicarbonate. And therefore, you get a strong ion difference of 34, and therefore, you will not cause acidosis by the administration of Ringer lactate. Right? So then comes the question of what would I do in hepatic surgery? Now, you'll find most cirrhotics, even patients with end-stage liver disease coming for transplant, don't really start off with lactates of 7 or 9. right? So lactates are usually around 2 or maybe 1.5 at the beginning of surgery. So even in these patients, a rise in lactate will actually coincide with an anapatic phase, or in hepatocellular carcinoma, perhaps with the use of the Pringle maneuver, inflow occlusion, or an arterial compromise to the liver. Therefore, in these patients, and also in patients with malignancy who always have a risk of developing sepsis overtly or subtly during the surgery, the lactate that I measure on the ABG will tell me how the body is responding. What kind, should I extubate on table? If I have a lactate of 8 at 1 hour before surgery and 8.3 towards the end, I'm not going to extubate. So I need to make sure that this rise in lactate is only because the inability of the body to metabolize the lactate, and not because of the lactate that I have extraneously administered in the form of ringer lactate. So the answer is self-explanatory. I'm sure all of you do the same thing. We will obviously switch over to an acetate containing solution. Now, the most popular one, I think, across all hospitals in India is a plasma light, which you can see is absolutely amazingly similar in its constituents electrolytes to that of plasma. Right? Its chloride is very comfortably poised at 98. Therefore, you're not going to get hyperchloremia, but just come down, right? We said that ringer lactate has 27 or 28 millimoles of lactate that gets converted to bicarbonate, whereas plasma light has 27 of acetate and 23 of gluconate. So am I going to cause alkalosis when I give plasma light solution? This is something that I asked, I don't know if people remember, I asked this in Bombay in 2011 and I didn't get a clear answer. But after probing and deducing, I finally understood that this gluconate is added to maintain a stability of the plasma light solution and is actually excreted unchanged by the kidney. And therefore, administering a liter of plasma light is not going to cause an increase in alkalosis to the patient. So, are there any advantages, any other advantages of acetate versus lactate? Well, they say that the production of bicarbonate from acetate is as soon as 15 minutes. Is that good or bad? I don't know. But lactate, it's in ringer lactate, it's delayed. The respiratory quotient is slightly less. Now, the biggest advantage to me is acetate can be metabolized by non-hepatic sites as well. Then it does not, whereas ringer lactate theoretically has a side effect that it can increase the blood sugar levels. That does not happen with the administration of acetate, right? Also, it does not bind to ionized calcium, and we believe that it does not interfere with levels of lactate as a marker. Now, I remember Dr. Divatia mentioning that lactate was used as a constituent of the dialysate fluid, and there were reports that it caused hypotension when it was introduced. However, I don't know whether the hypotension was actually due to the acetate or due to other causes in the patient with renal failure who needed dialysis. We don't clinically see any hypotension, nor do we see any dyselectrolytemia when you're using it in patients, both adults and even pediatrics. Now coming to the next fluid, can we use colloids in abdominal surgery? Somehow the world has become very prejudiced ever since, I think, September 2013, when there was a publication in the hospitals of England, UK, and Ireland, saying that the administration of starch to septic patients increased the incidence of mortality and renal failure. Now, since then, the use overall has substantially reduced. However, this is the Australian reference where they say for non-septic patients, there is no evidence of increased risk of mortality or the need for dialysis. Now, this hydroxyethyl, this is about hydroxyethyl starch. This can come either in normal saline base, or it can come as a combination with a balanced salt solution. So we did a very small study of 25 patients each. All these patients underwent major abdominal surgery, of which 80% were malignancies. Now, 25 of them just got crystalloids. 25 got 20 ml per kg of hydroxyethyl starch, and 25 got 20 ml per kg of gelatin. And we looked at serum creatinine, we looked at PT-INR and APTT, and we also looked at fibrinogen levels. The use of vasopressors, transfusion of products, length of ICU stay, and return of bowel function were similar. We did not find any change in the renal functions or in the coagulation. However, the group that received control, that is, did not receive starch, was found to have a higher level of fibrinogen, which is like a compensatory situation that we see, compensatory procoagulant that we see after major surgery. So other than saying it is probably reasonably safe to use it in patients who were ASA 1 and 2, did not have renal dysfunction, and were not at risk of developing sepsis or renal failure during surgeries, can be given a calculated volume under supervision, right? So this is what we probably use. In another large randomized trial that compared hydroxyethyl starch versus saline as volume replacement therapy in patients who were at high risk undergoing abdominal surgery. So I think here they had close to, I think 800 patients, about 390 receiving saline and, receiving hydroxyethyl starch in a saline or plain saline. And the primary outcome in this study was a mortality or major complication as they had defined at 14 days. And secondary outcome included the 28 and 90-day mortality as well as other complications. Now, 36% of the group that received saline. Sorry, did I miss something? Yeah, 36% of patients who received the saline. I hope everybody can hear me. I just realized there's a mistake. Okay, thank you.
Yeah.
Right, thank you. So 36% of patients who received saline versus, hydroxyethyl starch versus 32% that received saline developed complications as part of the primary outcome. And when you looked at the 28-day mortality, it appeared slightly higher in the hydroxyethyl starch group, but this was not statistically significant. So conclusion was, amongst patients who had a risk of postoperative kidney injury and undergoing major surgery, the use of hydroxyethyl starch versus normal saline did not result in a significant difference in composite outcome of death or major operative complications. However, it does not endorse the use of hydroxyethyl starch for these surgeries. I don't think any of us are going to touch starch if we see a creatinine that's higher than 1.2, 1.3. What about gelaspan? This is a colloidal plasma volume substitute in an isotonic, in a balanced salt solution. So it's rather comfortable to use. And I know that the use is very center specific. There are centers that believe that you should not waste products and you can use a colloid when it is needed, right? The only catch here is that it may be associated with coagulation abnormalities because it may affect the von Willebrand factor. And occasionally, nonetheless, at some time, it can cause anaphylaxis, which can be devastating if it were, say, a living donor or another patient undergoing a surgery, which is where you shouldn't have any complications, right? So anaphylaxis can occur, and this will take you off guard and may increase the morbidity after surgery. And that's something you need to remember with gelatins. What about albumin? So albumin, we know, will contribute to intravascular oncotic pressure. My students love to use it. If there's hypotension before the blood, there'll be a bottle of albumin on the desk. That's because ma'am said you can't use starch or gelatins. So what does it really do? I believe that its use needs to be regulated. It is expensive. It is derived from human plasma. It can cause anaphylaxis, and it does have the risk of transmission of infection. Therefore, use it judiciously. It helps in binding and transport of albumin, bilirubin, and drugs. It does have antioxidant effects, has a role perhaps in the stabilization of the endothelial cell membrane, and has an antithrombotic effect by binding to nitric oxide and prolonging its anti-aggregatory effects on the platelets. It's supposed to be nephrotoxic in liver disorders. I think clinically we use it in situations of HRS, the hepatorenal syndrome, where terlipressin albumin works wonders. It brings down a creatinine of 3.5 back to 1.6 or 1.7. So when would I use it? For want of an alternate colloid, because it is safe. It doesn't cause anaphylaxis. It doesn't cause renal injury. The studies that have been published earlier in 2004 and 2014 actually endorse its safety. And perhaps in some cases, you could have a reduction in AKI, an improvement in circulatory volume, and a reduction in the occurrence of lung injury. So conclusions on the type of fluid, balanced salt solutions are definitely superior to normal saline. Acetate-based solutions are safe and appear advantageous where lactate measurements are important. HAS does not appear to have an advantage over crystalloids, and in the context of AKI cannot be recommended for a routine use. Okay, this is all about what fluid. Now, second, we move on to how much fluid should I give. So how do I know how much of fluid can I give? We all talk left and right saying CVP is unreliable, or don't talk about that numbers, it is useless. The study of 8 mares or whatever, and it's like the toss of a coin. Then what else do I do? Right. So we had, I think, again, this was about 12 to 15 years ago when we had monitors that told us by looking at an arterial pulse trace, you can actually design the fluid responsiveness and then design how much fluid is to be given. And most of the centers that do major abdominal surgery have procured one or the other of the monitor, the Vigilio, and subsequently there was another platform called the EV1000. Essentially, it looked at the pulse contour, and if the pulse pressure variation or stroke volume variation was more than a particular number, this varied depending upon the generation of the Vigilio monitor, more than 12 or more than 10, you needed to give fluids, and you tried to keep the SVV less than 10. This meant that you had adequate fluid. This also allowed you to get a measure of the systemic vascular resistance when you fed in the CVP. So looking at a cardiac output and the SVR, you knew reasonably well whether you had to give fluids or you had to give a vasopressor to increase the systemic vascular resistance. What about our experience in abdominal surgery? This was long ago, 2016, when this monitor was perhaps started to be used widely in our center. We just used it for about 60 patients and found, strangely, that compared to the CVP, the fluid resuscitation was probably lesser, and the length of the ICU stay was shorter in the patients who had fluid replacement based upon stroke volume variation rather than the standard, which was looking at the CVP and urine output. Right. Now, this study again is published most recently, and it talks about this. The study that we did was abdominal surgery, again comprising 85% of malignancies, but not exclusively malignancy. This study that has come out much later again has 60 patients where they looked at stroke volume variation and impact on bowel function. And they said that it did not have any significant difference on bowel functions, but the patients had a shorter length of ICU stay and had lesser pain scores and needed lesser post-operative analgesia. So it was a result that was not their primary objective, but nonetheless, this was their conclusion at the end of stroke volume variation on colorectal surgeries. So now I'm going to put across a scenario. Again, this is a Whipple. A 48-year-old gentleman is undergoing a major pancreatic resection Whipple, and here the tumor is invading into the SMV. So as per practice, open surgery, there is an epidural and GA. Epidural is not activated intraoperatively. I think, I'm not sure if morphine was given. 1.5 liters of blood loss, replaced with 3 units of packed cells and 1 unit of FFP. And then, because there were no blood this thing, and because the anesthetist felt that the SVV was high and he had already given about 12 units of crystalloids, 1 unit of 20% albumin is started, and rather slowly at 25 ml per hour. 15 minutes after starting the infusion, there is a sudden increase in the heart rate from 80 to 160. And the BP just drops down from a value of 90 or 100 to about 40 by 20. The peak airway pressure that you see on the monitor ventilator workstation from 22 becomes 40. Now you have a monitor, this flow track connected. The CVP stays at 5. The SVR is about 350 dynes. The air entry bilaterally shows wheeze and minimal frothy secretions have come, and the surgeon is wondering what has happened. What do you think has happened in this case? I know it's not interactive, so I'll just go back. So this is what actually happened, and this is real. Albumin was started, and as I mentioned some time ago, it's human albumin. It has antigens. It can cause an anaphylaxis, which is exactly what happened. And when it happens, it takes you completely by surprise, right? So again, how did we manage? Obviously, we stopped. We gave steroids. We gave diuretics. We increased the PEEP, and then we started adrenaline infusion, and the patient recovered, and the surgery was completed uneventfully, right? Another patient undergoing surgery for lower esophageal malignancy. Surgery is uneventful. This is an IVLUI. No, sorry, this is a gastrectomy, no thoracic. Surgery is uneventful, GA with epidural anesthesia. After the lower anastomosis and closure of the diaphragm, patient develops tachycardia, a fall in BP from 120 to about 90, and the CVP rises from 15 to 18 millimeters mercury, or is that centimeters? Millimeters mercury. A flow tract Vigilio is connected, shows a low cardiac output, 2.5, stroke volume variation of 16, and an SVR that is high. Any thoughts on what this could be? So echocardiogram, a transthoracic echo, this is not a picture for that patient, but this is nearly what we saw. So surgeon, when he was taking a suture through the lower end of the esophagus, went through the pericardium and caused a pericardial effusion, which caused a tamponade in this patient. Now, I'm not saying whether the stroke volume variation helped you, but you can see the trends, and this may help you to exclude the causes of hypotension. The next, sorry. Why do we need to focus on blood pressure maintenance during surgery? So we are talking about fluids. We are talking about how we know how much fluid to give, but all this fluid is targeting the blood pressure. What is the need to focus on the blood pressure? So the guidelines would recommend to maintain a mean arterial pressure of more than 65 and a systolic blood pressure more than 100. However, the recent concerns are that you know that 65 is not going to be enough for a patient who's been chronically hypertensive and has a mean arterial pressure definitely more than 100. How can you say that during anesthesia for 8 hours, keeping the map just above 65 to 70 is going to be okay for him? Right. So this study published in JAMA looked at individualized, meaning blood pressure that was kept at between 10% of the baseline value versus standard blood pressure management strategies on post-operative organ dysfunction among high-risk patients undergoing major abdominal surgery. This was called the INPRESS, intraoperative norepinephrine to control arterial pressure study. And like all studies in JAMA, this was multicentric randomized parallel group in 9 university and non-university hospitals. So about 300 patients were identified to have a risk of postoperative complications with the preoperative AKI risk of class 3 or higher, and who underwent major surgery lasting for more than 2 hours were enrolled in the study, which took 4 years. Now, the individualized management strategy was aimed to achieve a systolic blood pressure within 10% of the patient's baseline value, while standard management strategy was keep the systolic above 80 or 40% below the reference value, which I think is a bit extreme, right? And predictably, 38.1% of the patients in the intervention management versus 51.7% had organ dysfunction on day 7, and this actually, the gap widened further at day 30, where you had 46 versus 62% of patients who had problem. So definitely those who do a lot of abdominal surgery and who are motivated to do, something new and different will be focusing on this, as I have. So what about goal-directed therapy? Goal-directed therapy took the world by storm some years ago, and today we're finding it less and less. And the reason for that is because you can't do goal-directed therapy when every surgeon wants to do laparoscopy or robotic. Where is the goal here, right? You're moving to extremely minimal fluids. You're looking at different parameters, and most of the time you really don't have a clue of what the IVC filling is unless you're going to look at the IVC on the laparoscope. A meta-analysis of 20 studies involving 2,000 patients showed that although goal-directed fluid therapy can reduce morbidity and length of ICU stay, it did not reduce mortality or the incidence of paralytic ileus. Of course, one can use the ultrasound, but during an abdominal surgery, this really goes out to the picture. They say that mechanical ventilated patients, the responsiveness is likely if the IVC distensibility, which is given by maximum minus minimum diameter divided by the minimum diameter into 100, is more than about 18%. Now, coming back to how can I predict that hypotension is happening so that I know when I can give fluid? The hypotension prediction index is a new artificial intelligence-based learning introduced by Edwards Life Sciences, where they said based upon looking at the characteristics of the arterial pulse contour, they could look at the contractility and the compliance and the peripheral effects. So they looked at about nearly 2.6 million features from the arterial blood pressure waveform, which is again derived from artificial intelligence, right? And how does it work? So they, from a database of 1,334 patients, they looked at about 50,000 events of hypotension and about 150,000 non-events, and compiled an algorithm which would be used to predict that hypotension was going to happen sooner than the clinician would recognize by his normal indices of monitoring. In addition, they also introduced dp by dt, which is a measure of contractility, and EA-dyne, which is a measure of dynamic arterial elastance, both of which would give you contractility as well as afterload and help you in the management of the patients. So a HPI value that was 85 and higher is likely to predict the occurrence of hypotension. And studies have shown that this HPI can predict the occurrence of hypotension as early as 15 minutes before the actual occurrence of hypotension with about 80% accuracy. Now, lesser, 10 minutes and 5 minutes, the accuracy gets even better. And another study has shown that when you treat hypotension based upon HPI, the number of actual hypotension cases was 8 in the group that received the intervention as per HPI versus, sorry, the time to respond to hypotension was 8 minutes in the intervention group and 32 minutes in the non-intervention group, therefore highlighting that there is a possible role for the use of the HPI. Now, what is the drawback, if at all there is any, with this? The HPI, it becomes insensitive when there is vascular clamping. So when you have a hepatic surgery and the IVC is clamped, this becomes unreliable. And if you read the articles on this monitor, they very clearly say it is not useful in liver surgery. So that takes away a whole proportion of cases where you might want to use it, right? Again, in aortic clamping, I'm not sure of the utility, but then it's like, you're not able to use it in situations where you might need it the most. Plus, it comes with a whopping cost of about 40 lakhs. So this is what has probably limited its use at my center. Centers who use it more extensively would definitely have identified advantages from it. And I'm sure they will come out with publications of its utility in the reduction and treatment management of hypotension. Now, what I believe in more recently for the management of fluid is, of course, the Pico monitors. And Gettinge has come up with a newer Pico monitor, which is slightly less expensive compared to the original Volume View by Edwards or the Pico by the other company. Here, what is done is very simple. It's a combination of thermodilution as well as a central arterial blood pressure. So you put in a central line, 7 French IJV, to which you place an adapter, and thermodilution is performed as you would in the intermittent cardiac output measurement using a Swan guns, right? So you give ice cold saline that passes out through the heart, and this ice cold saline temperature is picked up by the thermistor, which is located at the end of the femoral artery, right? So this is the curve that is derived from it, and the cardiac output is calculated from a formula that looks at the blood temperature, injectate temperature, volume of injectate, as well as the area under the curve. So this is what the cardiac output is derived from. In addition to this, this gives an effect of the mean transit time, which refers to the first half of the curve and the exponential downslope time. And these are used in the calculation of the intrathoracic thermal volume and pulmonary thermal volume, which in turn will give you your global end diastolic volume. It also helps in the calculation of extravascular lung water. And when the extravascular lung water values cross beyond the normal values of about 3 to 7 ml per kg, you know your patient is going into pulmonary edema. And this is very useful in major surgeries, including liver surgery, where you may not have a clue of how to manage the hypotension or how to prevent the pulmonary edema before it occurs. Pulmonary vascular permeability index is similar, refers to capillary permeability and refers to pulmonary edema, which could be anaphylactic or due to other cardiac causes. While simultaneously, this monitor gives you a pulse contour analysis and cardiac output assessment based upon the pulse wave. right? Additional monitors of contractility and cardiac function, cardiac power index are also available. I've just begun to use it, so its implication is yet to impact me. But I'm sure those who have used it longer will know that probably this can be used with a reasonable margin of safety with some information. And unlike other monitors where the disc or the cassette gets used, then you can't move it into the ICU. The patient can be shifted with the same monitor into the ICU for a few days, should he need that kind of support. Right? Now, coming to the last part of my discussion, I think I'm on time, liberal versus restrictive fluid strategies. So for me, as I said, once the surgeons stopped doing open and moved over to laparoscopic or robotic, the fluid requirements came down drastically. So while my open surgery would take about 4 to 6 ml per kg per hour, my minimally invasive starts off at 2 ml per kg per hour, provided the patient has had his correction for fasting. So we all know that in the study that was published by Dr. Miles and his team in 2018, there was a major kind of negative impact for the use of restrictive fluid strategy in the 900 odd, was it 900 or was it 1,500 patients? I think I'm not sure, where they looked at patients who had a restrictive fluid strategy with an overall cumulative fluid balance of about 2.5 liters over the perioperative period versus the other group that had 6-liter fluid balance. Right now, here, what I did not pick up from reading this was, of course, a very large multi-centric trial, and I'm sure it was standardized. What I did not pick up on reading the article was what were the interventions when the BP was low, or when the lactate was high, or when the urine output was low. Here in this study, they said that the risk of renal dysfunction was much higher. I think it was 8.2 versus 5 in the restrictive versus the liberal group. But when I do a minimally restrictive strategy, it is always tailored to certain endpoints. Of course, I cannot use stroke volume variation in laparoscopic surgery, but we do look at the mean arterial pressure. We do look at the urine output, and we do look at lactates. And when any of these crosses the red flag sign, we intervene by giving 250 ml of fluid or a diuretic as it may be needed. So in my clinical experience, using this with those tags attached is absolutely safe. Right? So, and this is a picture of the robotic arms for a donor nephrectomy, where the liver right lobe is actually harvested through a phenestrine incision. So what we did in colorectal surgery was to compare two groups. We called it liberal and restrictive. I think the definition is very varied and varies from each investigator. We put it as 2 ml as restrictive and 4 ml as liberal. And as I said, we intervened whenever the output fell less than 0.5 ml kg, or the MAP became less than 65, or the lactate crossed 4.5. Why did we keep that threshold? Because in laparoscopic surgery, invariably after 6 hours surgery, there is elevation in lactate. It could vary, right? If your patient is a bit dehydrated at the start, then also we notice that the lactates are a bit high. So does the amount of fluid make a difference in outcomes in cancer surgery? A perioperative fluid therapy on short-term outcomes and 5-year survival in patients undergoing colorectal cancer surgery. Here, a cohort study that included all consecutive patients operated with APR for colorectal cancer between 2002 and 2007 at Sweden. So they assessed the impact of a restrictive perioperative fluid therapy, which was less than 3 liters on the day of surgery, to the higher than that. So 911 patients included. Now, they found that those who had less than 3 liters of IV fluids on the day of surgery had a lower risk of complications and lower risk of symptoms delaying discharge from the OR, as well as a shorter length of stay. The funny thing was, when they looked at a Cox regression analysis, correcting for confounders, cancer-specific death was reduced with a 55% hazard ratio 0.45 for patients who got less than 3 liters compared to patients that received 3 liters, saying if you reduce the fluids per operatively, it's possible that you're actually preventing the recurrence of cancer 5 years later. This was the inference in this large study. Right. And again, this study very categorically showed that if you increase the amount of fluid that you give, you definitely increase the complications. And here it shows as an increase in the length of stay as well as postoperative symptoms and postoperative complication. Now, whenever we give fluid, we always wonder, at what time do I give vasopressor versus ionotrope and which one? So we know what are the things that are commonly available. Phenylephrine, which is a pure alpha-1 agonist, right, may cause a reflex bradycardia, and it produces peripheral arteriolar vasoconstriction, while norepinephrine has mixed alpha-1 and beta-1 more than beta-2, slightly more alpha activity compared to beta activity. Therefore, it does not cause brady and may either sustain or marginally increase the heart rate. Vasopressin will act on the V1 receptors. Dobutamine is a beta-1 agonist, and it also increases the contractility while having an afterload dilatory effect. Mildrenone is a phosphodiesterase inhibitor, which acts by increasing levels of cyclic AMP and therefore causes vasodilatation as well as cardiac stimulation. So, what would I use? In patients with normal cardiac status, we all know we use norepinephrine, and the dose I use is between 0.02 to 0.2 most of the times. Right? Contraindications or concerns are when the patient may have severe LV dysfunction or higher degrees of diastolic dysfunction. And of course, the dose steps up in sepsis and refractory hypotension. So does this cause any harm? Now, this meta-analysis again looked at perioperative use of vasoactive agents and did not find any adverse outcome. And the same thing was found in one of our studies for patients who underwent donor hepatectomy who needed a restrictive strategy, and in whom we use norepinephrine in a dose between 0.02 to 0.08. Absolutely no difference in any kind of postoperative outcome, length of stay, or lactates and bicarbonate, which was primarily looked at in our study. So when norepinephrine, again, you use it in splanchnic vasodilatory states and sometimes in EC or ARB blocker-induced hypotension, adrenaline infusions and anaphylaxis, and in hypotension, which is unresponsive to the primary vasopressors. Dobutamine, sometimes when you want to increase the contractility with a slight reduction in afterload, beware of tachycardia that is always there. Mildrenone can be considered in ventricular dysfunction to improve the function of the cardiac myocyte, can also be considered in the management of RV dysfunction and pulmonary hypertension. So to conclude, restrictive fluid strategies are recognized as a primary line of management in major abdominal surgery. Static hemodynamic indices, heart rate, mean arterial pressure, urinary output, lactate levels may guide adequacy of circulation and fluid replacement. The dynamic variables may be useful in open surgery and has limited use in minimally invasive surgery, where you have to rely on other parameters or the direct visualization of the IVC filling as seen or assessed by the surgeon. Norepinephrine is safe and appears as a vasopressor of choice in the management of intraoperative hypertension. And vasopressin is useful in vasodilatory states and in the treatment of hypertension with AC inhibitors. Gelatins versus starches. Gelatins may have some benefit. There's limited literature. I really don't know why. And anaphylaxis, when it happens, can be kind of devastating in the management. Albumin is safe, has an increased cost, and possibility of transmission of infections and occurrence of anaphylaxis exists. And I would use half normal saline with added bicarbonate to get an isoosmotic solution in the context of a hyperkalemia. Thank you.
Thank you so much, ma'am.
Thank
you so much for the interesting session, ma'am. I think though this was a big topic, but you had made it so simple, and not only the evidence, but you have put up so many important points which will be important for many of us to learn. So we have certain questions for you, ma'am.
Yeah.
So Dr. Pradeep wants to ask, is there any role of dynamic variables in laparoscopic surgery?
If you ask the company person, they will actually say that you can look at the stroke volume after giving a bolus. Stroke volume variation, of course, is absolutely confounded. You can't go by that. But he will say, look at the cardiac output or stroke volume. But basically, I have personally tried it and haven't been convinced by it. So those who use it and believe in it may have a better experience than me. I truly am a non-believer at this stage.
So do you think, madam, maybe the change in trends, are they of some importance when we are using those variables where single reading may not be important? You rightly said level. Maybe.
Perhaps it would. But again, the magnitude of that versus the costs and the possible impact, to me, it's like a weak balance. Again, those who may believe in it and who have evidence for it, it's okay. I don't use it in my lab surgeries.
Ma'am, one of the participants want to ask what percentage of albumin do you use as colloid intraoperatively? In fact, I will request you that you mention in one of the slides the way you use albumin. Can you mention which percentage and usually at what point
Sure.
do you give albumin during the surgery, and what is your
Right.
infusion rate? Do you dilute them
Right.
into line as some people do, or you give them as a slow infusion? Can you just share your practice, ma'am?
Yeah. So again, I believe to some extent albumin is overused. It is expensive and comes with its list of complication. When you give it to patients, you can see that they don't swell up, which they would if you give too much of crystalloids. So how I give is usually I wait for the end of the surgery, meaning a tumor to come out and when major resection has happened, or I might start if there is evidence of mild bowel edema. For adults, I only use 20% albumin, and either I give it at a slow rate directly, 25% albumin. Oh, sorry, it's 20%. 20%. I would give it directly from the bottle slowly, or in major surgeries like liver surgeries, I give it as an infusion at 25 ml per hour. So, it's just filled up and given over 4 hours, and it works really well. I believe that's when it would stay in the circulation instead of being washed away.
Do
I
you
hope
also
that makes sense.
Yeah, it makes sense. It absolutely makes sense. And as you mentioned in one of your slides, there is some evidence for its use. Even if you see the surviving sepsis guidelines and other sepsis-related intervention, surgical intervention, they do mention its use. But you rightly said that's a human product. It has its own limitation, and
Yes.
should be very cautiously used. Do you relate the albumin infusion also to the hemodynamics at some point of time? You said you see bowel edema, you see the amount of crystalloid which has already been given, and do you also relate
Right.
at some that
So
this is
it's
my
mainly if, say, a patient has ascites or, that kind of fluid, then I would replace about, like you say, in liver surgery, 7 to 8 grams per liter of ascites, which means even if he has 5 liters ascites, you give 2 bottles of 100 ml albumin. That's all. The rest of it, again, is tailored to the need, like, is there bowel edema? Is my patient losing so much of fluid, inability to maintain the blood pressure despite hiking up the vasopressors, right? I'm not able to balance and therefore I'm not having fluid and it doesn't justify any form of transfusion. So intra-op until tumor comes out, if there is an indication to give blood, probably there would be that first before I start my albumin. Albumin, once the tumor comes out, I would give. I'm not sure what else I can say. Would I look at any variables? If I had high output, CVP unable to maintain, MAP is low despite giving, say, 0.2 mites of noradrenaline, then I might consider use of albumin.
That's true, ma'am. I think this is one of the very practical tips you have given, because there is nothing called sure shot that this is the point that you should give albumin. The patient, you mentioned in one of the slide, the individualized care has to be given. So you talked
Yes.
about colloid, the crystalloid, then the albumin, then the blood products, and you do talk about vasopressors also. So it has to be individualized based on the patient response. Somebody wants to ask, madam, you mentioned also Hemaxil versus albumin.
Yeah.
What is
So
the
again, the gelatin use is very center specific. So we really don't believe in gelatin. So I just about managed to do it for my study. Although it was safe, I did not encounter anaphylaxis in this group, but I have seen anaphylaxis in other patients, like when we do liver donors or something. And when it happens in a donor, it's something you really don't want to see happen. So with that, our use on it is very less. So for one, I don't think other than liver surgery, I really transfuse albumin for many patients. It's very limited towards the end of surgery when there is stability and only to reduce any bowel edema. So using a colloid is only if I have to use large volumes of fluid. And today we are looking at 80% of the surgeries are minimally invasive. So there's no question of large volume. It's only when they're using massive amounts of blood. Perhaps if, patient came in as an emergency, bleeding, blood is not arranged, and I didn't have anything else, I would start off with one of them. Otherwise, my dependence on a synthetic colloid is very minimal today. So I'm not sure if how I can answer your question. It is very center specific, experience specific, and based on your comfort. I know liver units which used a lot. I also know liver units that moved away because of anaphylaxis. So when you have one bad experience, you stay away from it subconsciously. So I guess it's our policy. Like my surgeon said, if you're doing well without it, why are you trying to bring it in? And I didn't have an answer for that. So we rather stayed away from most of these. I do use Heta starch in this ASA 1 and 2 patients if I find that the volume that I'm giving is going more, crystalloid volume, otherwise very rarely.
Right. Uh, People say we do have a lot of crystalloids available, ma'am. Lactate-based solution, acetate-based solution, and now we have stereofundin and plasmalite balanced salt solution. So when you have a major fluid shifts and you want to give a lot of crystalloids, so do you have any concerns using these variety of crystalloids we have?
So as I said, the first line is always ringer lactate. And then when the lactate starts to rise from whatever cause, we move to plasma light or the balanced salt solution that contains an acetate. Simply because if a patient is losing that much blood, I believe that there could be some inability to metabolize lactate. For me, first line is ringer lactate. If lactate goes high, I move to plasma light. Stereofundin, I've used it for donors when other fluids were not available. It has hyperchloremia in the constituent of the solution. Fortunately, when you give it clinically to patients, it does not result in hyperchloremia. So when you look at any thing that you don't like about stereofundin, that's the chloride level. And does it affect clinically? In my experience, it did not. So what were the other things that you said? Half normal saline and normal saline. Normal saline, I think I only use in TURP surgery today, very, very rarely in any other situation, maybe other hyponatremia and whatever. But if there is a hyperkalemia during any of these abdominal surgeries, then I move over to giving half normal saline. Half normal saline obviously has only 75 milliequivalents of sodium. And I was told by a senior colleague of mine, she gave me a calculation which I never remember offhand. If you add 37.5 cc of 8.4 solution of sodium bicarbonate, you actually reconstitute the sodium level to it about 140, right? And you're also adding a base to the solution. So by giving half NS with added soda bicarb, you're actually giving a balanced salt solution with the exclusion of potassium. And that has been the backbone for our problems whenever patient has renal dysfunction or hyperkalemia during surgery.
I think a nice tip, ma'am. Nice tip, because otherwise people are concerned with normal saline and half normal saline. But I think this is an important tip. I don't think it is mentioned in the book somewhere, but I think this is a very important practical tip from your side, ma'am.
Yeah, I'm sure there are other people. And the person who told me was Dr. Purnima Dhar. So
okay.
I think she was the one who taught me that.
Ma'am, one of the participants wants to ask about the cytoreductive surgeries, interval cytoreductive surgeries. I think it goes a turmoil.
We don't do that many cytoreductive. I think Dr. Sohan, if he's still hanging on, will answer all those questions. He probably knows more than me. We do less of that.
If Sohan is there, he can unmute, or I can share my
experience. Perhaps you could say that. Yeah,
Sohan
sure.
is there. I will request Sohan to just say something
about it.
Doesn't
look like he's there.
Oh, not sure. So what we do at our center is, yes, as Madam mentioned in one of the slides, we use dynamic monitors for them. We usually go for a little restrictive fluid in the initial phases, use the crystalloids, basically the balanced salt solution. And as Madam also mentioned in one of the slides, rather than giving overzealously boluses of fluids, we do keep them at low doses of crystalloid, low doses of vasopressors in these patients, and slowly try to replace the fluids. And at times, depending upon the resection, depending upon the baseline albumin levels, we do supplement them with slew infusion of 20% albumin for them. And these patients, probably when they are going for HIPEC surgical procedure also, they will be given continued infusion of crystalloids over next 24 hours. The requirements remains little higher. So rather than giving boluses of 250 ml or 500 ml of fluids, we give them slowly and try to maintain the perfusion using vasopressors. And most of the time, we are able to bring lactate levels improve the urine output in next around 8 to 12 hours. So this tends to settle down. I think this is what Madam has told into various slides. So we have using the combination of these things, especially for cytoreductive and hypex surgeries. So I think, Madam, you have already covered majority of questions, and people
I think
are
Dr.
appreciating.
Indira has asked some question.
Madam Indra has asked,
In surgeries
in
like
sur-
Whipple, you see SIR is setting intraoperatively. You give fluids and then PPV decreases, and then after some time it goes up again. So do you keep giving fluids or do you start vasopressors? Definitely yeah, this is when the restrictive policy comes in. 10, 15 years ago, we may have rush fluid, but now we are very clear. If we believe we are giving, more fluids than a calculated amount for the loss, and say for open surgeries, 4 to 6 ml per kg, I would, without any hesitation, start NORAD. In fact, NORAD is there in the pump for 60, 70% of my patients. Either we are targeting a higher MAP or we are preventing this. So there's absolutely no problem in giving this norepinephrine because it helps you adhere to a restrictive thing, which in turn gives you better outcome. And we also know, I think I have published in one paper also, that it does not increase any of the markers, lactate or whatever. So it doesn't affect the outcome as well. So it's okay to go with vasopressors at a very low threshold.
I think this is an important point. We have to remove the taboo of using vasopressors, which sometimes people say that is for refractory hypotension, not responding to fluids. We have to use a combination of various regimes that we have. And you rightly said, even in your studies, and there are other studies we mentioned that it is not going to increase the morbidity. In fact, it is going to decrease the morbidity because especially the intra-abdominal surgeries, if you are overzealously giving more fluids, there will be bowel edema, the abdominal closure will be under pressure, there will be increased intra-abdominal pressure subsequently, and that will further compromise the perfusion of the organs. So I think, as you rightly said, Madam, it's combination of these things that probably improves the outcome.
Yeah.
So
I think Dr. Mallika has asked, will starting albumin from the start itself benefit? Mallika, I really don't believe in starting albumin very early, right? Unless, as I said, the patient has ascites, is extremely malnourished, in which case you shouldn't be taking him for a major surgery unless it's palliative. So I believe the albumin needs to be given and used very judiciously. So I would delay the start of the albumin until I believe what I'm giving stays in the patient and does what it's intended to do. Yeah, if you have ascites, then along with the drainage of ascites, it is important to replace the albumin. Again, as I said, 7 to 8 grams of albumin per liter of ascites. So depending on, the ascites volume, you can probably try starting as an infusion. I don't do too many cases with ascites with malignancy. I only look at end-stage liver disease with ascites. So probably my experience is limited in that context.
Ma'am, with regards to Dr. Argya wants to ask, with regards to the use of vasopressors, any experience with terlipressin for its use, Madam?
Yeah, terlipressin we use regularly in cirrhotic patients to actually reduce the occurrence of hepatorenal syndrome. So terlipressin comes as a double-edged sword because there are reports that it can cause splanchnic hypoperfusion and can worsen bowel ischemia. There are, again, studies which endorse its safety. But again, when we give terlipressin, I am very concerned. It works magic in patients with hepatorenal syndrome, and giving restricted fluid and volume loading, which means giving albumin along with terlipressin, is definitely the treatment of choice for hepatorenal syndrome or in other surgeries where you have a component of splanchnic vasodilatation, which is contributing to the hypotension. So would I routinely use it as a vasopressor in my surgery? No, I don't.
And ma'am, any concerns about using, Aragya still wants to ask, any concerns using epidural in this with local anesthetic where you are expecting there will be a huge amount of hemodynamic use of epidural catheter, epidural block?
Right. So that's what I said. Long ago, we were using local anesthetic infusions because we were kicked to think that epidural was acting. So once we realized that we are giving epidurals that work anyway, I've now started giving just morphine at the start. So most patients do very well for even up to 24 hours with 3 milligrams of morphine. And this thought was shared to me by my colleague, Dr. Mary Thomas from RCC. So we just give it at the start and do not give a local anesthetic infusion at all during surgery unless there is hypertension, which we don't see. So we wait until the end, and if there is any pain, we start a more dilute solution towards closure. So when the patient wakes up, either the morphine itself covers the pain. In some patients, you can see they're pain-free for up to 24 hours post-op. Otherwise, if you believe they're having pain, you start the local anesthetic at closure when the patient's going to wake up and perceive pain. I do not routinely give local anesthetic during surgery today.
I think that's an important tip, and even certain literature says that using even intrathecal morphine, though it's a little outdated one, I've been using for almost all my CRS procedures, just giving around 4 to 7 mics per kg of intrathecal morphine, and it works wonderfully for at least maybe around 18
so
to
4
24
to 7 mics would mean like up to 420 or 480 mics morphine intrathecal. Isn't that a high dose?
Approximately, it will be say use around 4 mics, 60 kg, so it will be around 250 micrograms to 300 micrograms.
I think up to 300 is okay. Above that, I would be concerned. We use it in minimally invasive surgery today as a very simple analgesic option. And we found that the intraoperative opioid dose is coming. I mean, that paper is still being processed by my student. Which concentration of albumin do you use in pediatrics? Adults, it is that 20%. Children, we use 5%. Or even in children, because of concerns about, compromising the sterility if you were to dilute, we just give it as infusions of, say, 2 to 3 ml per hour. And at the same time, you're giving crystalloid. So we believe the mixing happens in the body. Technically, you're supposed to answer 5% for the exam. Yeah, sorry.
I think we have covered many questions, quite interesting discussion, ma'am, and many carry-home tips which will be useful to our clinical practice. So I think we are already crossed by 10 minutes, but it was really a very interesting session, ma'am. And last question by Dr. Punita. She wants to still ask, how much bicarbonate do you add to normal saline, madam? You mentioned
37.5 cc of 8.4% to 500. Technically, 500 minus the 37.5 cc of half normal saline. Okay, so each bottle takes 37.5 cc of bicarb.
Perfect. So I think we should say now thank you to you, ma'am. Thank you so much for such a wonderful session. A difficult topic, always a controversial topic, but you have given so many key messages. I am sure that it will help us into our clinical practice. Thank you so much, ma'am. And I will hand over to Dr. Anjali for today's session. Over to Dr. Anjali, please.
Thank you very much. I would really like to thank our speaker as well as our chairperson because they've taken time out from their busy schedules. I can see that Dr. Garg is actually on the airport. He was taking an examination in Varanasi. And I would like to thank Dr. Lakshmi Kumar, her august presence. This is the first time that for a lecture we have crossed 84. We had 84 delegates at a time joining in, and I'm sure it's all because of Dr. Lakshmi's reputation that we've got such a crowd. And she's totally covered everything that could possibly have been covered in such a short time. Thank you very much, madam. And I would like to thank all our delegates as well for staying back for so long. Thank you very much. And at the very end, I would like to thank the ClearNet platform.
Thank you, Dr. Anjali, for having me in this group. Thank you.
Thank you. Ankita, would you like to end the session?
Yes, thank you so much, everyone. Thank you for your valuable insights. So with all your permission, can we conclude the session over here?
Yes, please.
Yes.
I'm hoping to meet you again on the platform very soon for the next session.
Thank you.
Thank
Bye.
you. Thank you.
Good night.
Good night.